Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm honored to welcome to the show Dr. Harry von Piekartz. Dr. von Piekartz is an extremely accomplished physical therapist that has contributed extensively to our profession with hundreds of works over the last several decades. In brief, he has a long history of teaching OMPT. He is also a well-known researcher on craniofacial pain topics, as well as a wide array of other important content areas. Additionally, he is a clinician, professor, and textbook author. We invited Dr. von Piekartz to the show today because he was recently the primary author of a paper in the Journal of Manual and Manipulative Therapy titled Diagnostic Accuracy and Validity of 3 Manual Examination Tests to Identify Alar Ligament Lesions, Results of a Blinded Case Control Study. Dr. von Piekartz, welcome to the show.
Good afternoon, Steve.
How are you doing today?
Yeah, good. We had a good day today, and we are now in Montreal to give a course, and we are very happy to be here.
Excellent. Yes, you are here today. You are from Europe, but you're in Canada teaching a course, if I understand correctly.
Yeah, we teach a course in oral-facial pain and cervical problems by the Krafthaar, where we also do courses in Montreal and also in the US. So now I'm here for 4 days for the course.
Excellent. And when folks finish these courses, they end up with a certification, is that correct?
Yeah, so this is the basic foundation course, and then there are 2 other advanced courses, and then they can do a certificate in craniofacial neuromusculoskeletal therapy.
Excellent. And for anyone interested in that, we said it's called CRAFTA, C-R-A-F-T-A.
Yes, that's the name, Craniofacial Therapy Academy. So we have an organization international where we give education for physical therapists, speech therapists, and dentists. But we have also a research group where we support, of course, the evidence of what we're doing in physical therapy.
Excellent, excellent. I've heard only great things about that course. And it is, of course, related to what we're talking about today because the research study in question has to do with the upper cervical spine and the alar ligament.
Indeed.
And to get that started, let's talk about the 3 tests that you included in the study. And if you could please describe for the audience why you picked those particular tests to include in your investigation.
Okay. We did 3 tests who are used in the practice very often, and also are tested before in other interreliability studies and validity studies. The first is the lateral bending test. It is a test where you grasp with your index finger and your thumb around C2. When you make a lateral flexion to the left, normally you get a rotation of the C2 to the left, but you feel also with your right index finger then if the spinal process of C2 comes to your finger. So if it is moving, then it is normal biomechanics of occiput C2. The second test is the rotation test in supine, where you fix C2 and you rotate to the right and the left. And you judge the range of motions where you compare with left and right. If there is more rotation, the test is, let's say, positive for an alar ligament for the contralateral side. And the third test is the lateral shear test. It is a linear movement where you fix one part of C2 and you move perpendicular from the left to the right, occiput C1 on C2. So if you do occiput C1 from the right to the left, you test the left ligament alar. So that's the test. So these are, let's say, simple tests to do for all manual physical therapists. And they also used already in other research. So we did this in the research to pick it up as a cluster of tests, and we compared it with MRIs.
Excellent. That makes a lot of sense to me. So they're common tests, they're easy to reproduce, and they're the types of things that, of course, all manual physical therapists should be good at.
Absolutely, absolutely.
And to take it a step further, can you tell us about the inter-examiner reliability of these 3 tests?
Yes, we did in a parallel study. We looked also with two examiners to the same test. And we have to say that the interoperability of these three tests, especially when you cluster them, when you take them together, is relatively moderate to acceptable to high. So we look to the agreement of this test, but also in compare with volunteers who had ligament alar problems and with normal, also volunteers who had no problems. And we see that the agreement of the lateral bending test was about 42%, not so high. And the rotation test, occiput C2, was about 50%, 51%, and the lateral shear was 49%. But if you compare them in a cluster, they go high about 84%. Yeah, and we did it also in compare with the whiplash-associated disorder patient we also use in this study what we talk about now. So we can say, all right, the interoperability is moderate till good, yeah, and that's a good point, I think.
And when you said that you did the cluster, I assume that you included all three tests together, not just two of three.
Yes, all three together, yes. So if all the three tests are, let's say, positive, the agreement is very high together.
And do we know the numbers if only two tests are positive?
I don't know by my head, but it was about 60, 61. I cannot remember anymore, but we want to publish this also later on. But it was a little bit lower, yes.
So from a clinical standpoint, having all three positives is pretty much the way you want to go.
Absolutely, yes.
And these tests are often performed in different positions. Say, for example, the seated position versus lying down supine. Can you speak for a moment about the utility of different positions?
Yeah, I think, of course, when you look to the first sitting position, this is, of course, more the functional position where patients have also their problems. So you can also imagine that you can get more reproducing signs of the patient. Also, the dynamics probably also from the alar ligaments is different. Yeah, we know this also from MRT studies. So, and you can also combine it more with other movements, so to get a reproducing sign. And also you can better look to the range in this functional position. Also, you can better look in sitting to the quality of movements. Maybe you see more motor control changes like hing movements or apprehension feelings, what you cannot see in supine. And also, especially also the oral facial activities like lip movements as associated movements and tongue position changes were very, I think, very important clinically to look to the behavior during the movements in sitting. The supine position had the advantage that this reduced gravity, and so you have not the really the head position and also the force of the head position is changed. So you can also assess more the resistance behavior from R1, R2, and the quality of movement. So to look to the neutral zone, the 0 to R1 zone, you can judge more better. And you can also see if the curve of resistance has changed, what can be correlated with clinical instability. And the control of passive movements, I think, is better because the patient is lying, and you can analyze better the resistance in compare with the symptoms. I think also, therefore, we have also to do some tests in supine, I think.
So, as is often the case, a combination of different tests is beneficial because from each one we're gaining different pieces of information to make a whole puzzle.
Yeah, absolutely. I think also that you compare it with other tests. It could be a good indication for the clinical instability, clinical pattern.
Now, during that description you just gave, one of the things that you mentioned that I think a lot of listeners might not be familiar with is looking for behavior of the tongue. So how does that relate to, for example, clinical instability that could exist around the alar ligament, and why is it something that we should be looking for clinically?
Yeah, it's a very interesting question, and I also did a little bit of reflection on the literature, but there's not really too much literature about the correlation functional between the tongue position, the tongue force, the tongue strength, and the cervical spine. We know that the tongue is innervated motorly by the hypoglottis nerve. He comes also partwise from the upper cervical spine. It's a cranial nerve. But also the tongue facilitates the cervical spine and also contraverse. So there's still a debate if first you get a facilitation from the cervical spine on the tongue or contraverse. So you see a lot of associated movements during cervical instability. Yeah? For instance, clinically, if you ask a patient to bring the tongue against the palate, you see other movements. The movement is mostly better, so it facilitates also. If you treat the cervical spine, you see also that sometimes the force and the strength and the coordination is better of the tongue. So there has to be a functional relation, anatomical relationship between it. So therefore also, I think also we have to look also to the tongue and the tongue strength and the tongue position during the movement. And we learned it from the patient who are cervical unstable because they make a lot of associated movement of the tongue. And I also do that a lot in the practice also, that we look first to the tongue position and then to the cervical spine position. Yeah.
So to try and put that into context a little bit, over the years we have expanded our thought of back pain to also include the pelvic floor.
Okay.
We didn't used to necessarily associate the two.
Yeah.
But as we learn more and we get a larger, more robust picture of how, different anatomical regions relate to each other, might it be true to say that, hey, we've looked at the cervical spine for a long time, we've looked at neck pain for a long time, but we've been missing this other adjacent thing that's involved. So in this particular instance, tongue position, etc.
Yeah.
So is that related to the neck, like we might say the pelvic floor is related to the low back?
All right, yeah. It's, I think also an enormous issue is of course the orofacial region. As we know that temporomandibular joint dysfunctions, but also orofacial nociception can increase trigeminal sensitivity, and can also give other changes in motor behavior of the cervical spine. There's really an association or correlation between the orofacial region. And the tongue plays also a very important role by the orofacial activity and also by the TMJ function. Yeah, that's clear. So I think also we have, of course, we are focused on the upper cervical spine and we look how is the integrity of these ligaments and how is the motor component. But we know from research also now that we also have to look to the other side, which can have a larger influence on the cervical spine behavior. Yes, absolutely.
So part of the message there, of course, is we need to be thorough. And speaking of which, in the study, one of the things you did that was a very strong aspect of this research is you utilized a radiologist to, confirm your findings, to correlate imaging with clinical findings. And I noticed that the radiologist in the study had 9 years of experience.
Yeah.
So it's a great thing. You want somebody who's experienced. Can you speak for a moment how this might relate in general to clinical practice, exactly why you formed it that way, and then how we should interpret it?
Okay. Yeah. First, I want to say something about when somebody is suspect from a cervical problem, and there's, let's say, something with the alar ligaments or the transfer ligaments, then there is made a standard MRI. And the standard MRI is mostly in supine with the mouth open, and they look to the integrity of the ligaments. This is done by the radiologist, but the interpretation comes from the orthopedic surgeon or the neurologist. The discussion is that what is in Europe is that the supine standard MRIs are not so gold standard, what we think. And so most people, and also radiologists, like the radiologists we work with, they do it in sitting also, or they have a specific protocol. And this radiologist, what he's doing is he take the patient in supine with a higher solution and look in functional position to the alar ligaments. And it is also done in this study we did. And so we can do that in supine, but also in sitting. And the sitting position is with an upright MRT, seems to be from studies from Piekartz and Kahl in 2008 that it is more sensitive than in supine. but it is not paid by the insurance company. So the patient has to pay it on his own. So they are sensitive, but it is not really accepted by the insurance companies because you see more, probably. And what we did in this study, we get the MRTs, the old MRTs, the standard MRTs. We get the new MRTs from the radiologist in functional position in a higher solution in supine. And all these persons who were volunteers had, by coincidence, also had a sitting MRT. So we could compare 3 MRTs together. Yes, and that was, of course, very nice to do. And we saw also that, and that was the conclusion also from the radiologist, that the agreement of these 3 MRTs is not so high. Yeah? So we take the special MRT from the radiologist in supine with a higher solution as the gold standard test in this study.
It's such a great example of the gap between clinical practice and research. The operative thing here being, of course, if we know from research or we believe from research that position A is better than position B, it's perhaps irrelevant if it's not paid for or the patient can't afford it.
Yeah, absolutely. Yeah, you're right. Yes. Yes. And in the study, we had the opportunity to also to have volunteers who had no problems and patients who have really an alar ligament rupture. And it was also concluded by the radiologist. But also the volunteers who had no problems get also the MRI in supine. So then we will say, okay, good, because of this specific higher solution MRT in functional position of the alar ligament, we are nearly by a gold standard test. And that was also the opinion of this radiologist, who is a special radiologist in this area. Yeah.
So one of the things we always talk about with imaging is false positives and false negatives. I would hope that in this instance you didn't get any false positives for ruptured alar ligaments when there wasn't one. What happened there?
Yeah, probably okay, that's the clinical expertise of the radiologist. So because we did this in this specific position, we probably have less false positive tests than usual. Yes.
And I have one last question for you. This is obviously very important information. Upper cervical spine instability, for example, is the type of thing we never want to miss in the clinic. But we all know, and you've outlined some of the details here, none of these tests are perfect, right? You didn't say it's 100% reliable, 100% valid, so on and so forth. So taking a realistic approach, a clinical approach to this, what's your best recommendation for how physiotherapists around the world should handle this general topic when approaching it clinically?
Okay, thank you for asking, Steve, for this question. I think this is very important because I hope all the colleagues don't see that you have to do the 3 tests and then you have an accuracy of 80%, what we also describe in this article. It's not. So you have to embed it in first a good subjective examination, yeah, with a forward reasoning character. Yeah, so you have to look to key features. What is the neck trauma? Was there a neck trauma? What kind of a pain is it? Mostly it's a local pain. Yeah, less radiation to the face. Is there progression of symptoms? Are let's say the associated symptoms like dizziness, paresthesia? Then we have to differentiate, of course, with red flags. Then cervical vascular diseases. What can also be interval with pain in the neck cancer, yeah, can also give local pain and instability. We know this. Possible cord signs like neurological diseases, what's coming up. So that we have to clear first. And then probably as a physical manual therapist, we have to look to the quality of movements. And you see that there is no closing down patterns. You see one movement is more than the other. Movement. You have to. Then we can embed the clustering of test of the alar ligament test. What we talked today about it, and and then at the end we get our confirmation with accessory movement test, and motor control test. And if we see the whole clinical pattern, then we can say, oh, maybe this is a functional instability with or without integrity changes of the alar ligaments, and then we can make basic for our management.
That's precisely the answer I would anticipate hearing. Hopefully all of our audience already knows that, we look at a wide variety of signs and symptoms before we come to a conclusion. So excellent on you for pointing that out. And, of course, we always have a process start to finish, and, we should implement that as thorough clinicians. So moving forward, I know you do a lot of research in not just this area, but others. Do you want to give us a sampling of the projects you're either currently working on or that you're going to work on in the near future? Yeah,
okay. We do now a project. We're nearly ready on parafunction, on bruxism, orofacial bruxism, on cervical impairments. Yeah, so we look to people who have really have cervical impairments. Bruxism. Do they have also cervical impairments more than? Because we know that from bruxism, a lot of patients have a little neck pain. So is that really the cause, also the orofacial region, or is it also controversy in the cervical spine? We look to the pain in cervical impairments. Sorry. And another thing, what we are very exciting about is the measure of pain and the facial expression. Yeah, so we can measure pain on different items, for instance, like the visual analytical scale, numerical rating scale. What we do now, we give an experimental pain in the neck, and we look to the facial expression, what kind of facial expression the person have in intensity and motor activity in the face. And it's very exciting because also for us in physical therapy, it can give a new dimension how to analyze pain. And that's what we're doing at this moment a lot.
On that last topic, and I ask this out of personal curiosity as somebody who's worked with a lot of different people from a lot of different cultural backgrounds, who do you think your sample population is going to be in that study looking at the facial expressions?
Yeah, okay, good question, because the facial expression, especially when you think of basic emotion, is in all cultures the same. Yeah, you have the same facial expression reflex. And there are also studies was done in different cultures, and the same. You see the same behavior of muscles by pain. Yeah? And there's a good study done by a German psychologist, Miriam Kunz. She is professor now in psychology in facial expression. She did it also in different cultures, and you have five different types of facial expressions in pain. And that we try now to analyze also by our patients. So yes, the facial expression in let's say, Asiatic people or in North European people or in American people seems to be the same. And that is what we can use then also in our...
Interesting. And right as you were giving that answer, I was thinking about my question. And part of what I was thinking was the fact that I'm not just looking at facial expressions, but when people have pain, their feet move, their hands move, they make, audible responses, etc. And I definitely notice differences in general, person to person and culture to culture. But I've never thought about it just isolated to facial expression before. So that's interesting.
Okay, yeah. Yeah, and also the non-verbal communication, of course, of the body is very important. Yeah.
So, this has been spectacular. Sometimes I assume that our audience likes to reach out and ask people questions. Is there a way that they can find you on the internet?
Yeah, okay. If you put on my name, harryvanpiekartz.com, you can come on the internet. There's an email address. They can ask questions if you want. I'm prepared to answer them. Yeah, in 1 or 2 days, if it is possible. Yes, of course, yeah.
Perfect. We can link to that in the show notes.
Okay.
Dr. Van Piekartz, it's been an honor and a pleasure to have you on the show today. We thank you for all of your contributions to the profession and hope to hear from you in the future.
Thank you. It was a pleasure to talk with you about this subject, Steve. Thank you very much.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.